Hey everyone, and welcome back for another deep dive.
Yes, welcome back.
This time, we are looking at some really interesting material all about parenteral nutrition.
Yes, very interesting and very clinically relevant too.
Absolutely, and I think it's particularly relevant to one of our listeners out there today.
Oh yeah, who's that?
We've got a great listener who is getting ready to take their LPN exam.
Oh wow, big exam coming up.
And this topic is right in the wheelhouse.
Front and center.
So we're going to really make sure we hit all the key points that you need to know to ace that test.
That's right, we've got all the goods from their study material.
Absolutely.
Let's break this down.
So we're talking about parenteral nutrition, or PN, as it's often abbreviated.
Yes, yeah.
This is basically a way to give someone nutrition when their gut just isn't cooperating.
Right. It's like a lifeline of nutrients going straight into the bloodstream, bypassing the whole digestion thing.
Exactly. So we're going to look at the difference between TPN and PPN.
Okay, love it.
We'll dig into what goes into those solutions.
The ingredients, the recipe, exactly when you would use each type.
When's the right time for TPN versus PPN?
All those nursing considerations so you know what to watch out for.
The need-to-knows.
And, of course, any potential complications.
Got to be prepared for those curveballs.
Exactly. So let's jump right into it.
All right, let's do it.
We're going to start by comparing TPN and PPN, which are the two main types of parenteral nutrition.
All right, total parenteral nutrition versus peripheral parenteral nutrition.
Right, TPN and PPN.
TPN and PPN can be kind of confusing.
Yeah, so let's start with TPN.
Okay.
Total parenteral nutrition, and this is like the all-inclusive package.
The deluxe model.
Exactly, nutritionally complete, providing everything the body needs.
All the bells and whistles.
Now, TPN solutions, they can be pretty strong.
Yes, strong is a good word for it. They're hypertonic.
Meaning
they have a higher concentration of stuff in them compared to our blood.
And this is where that 10% dextrose comes in.
Ah, yes, dextrose, the sugar rush.
If it's got more than 10% dextrose, it's hypertonic. And you have to give it into a central vein.
Why is that?
Because those big central veins can handle that concentrated solution.
It doesn't irritate the smaller veins.
Exactly. It gets diluted quickly.
It's smart.
So TPN is often used for patients who have high-calorie needs.
Makes sense. Got to keep those energy levels up.
Or if they're going to need nutritional support for a long time.
So long-term support.
Or if they need those higher concentrations of dextrose.
Got it.
Now, on the other side of the coin, we have PPN.
PPN, the little sibling of TPN.
Right, peripheral parenteral nutrition. And this one goes into a smaller peripheral vein.
Okay, so like the veins in your arms or hands.
Exactly. And because of that, it can't be as concentrated as TPN.
Ah, it's got to be gentler on those smaller veins.
Right, so it has to be isotonic.
Isotonic meaning?
It means that the concentration is similar to our blood.
Oh, I see. So it's more compatible with our delicate veins.
Exactly. And that's why PPN solutions can't have more than 10% dextrose and 5% amino acids.
Okay, so it's limited to lower concentrations.
Right, and it's usually only used for a short time, like 7 to 10 days.
So short-term nutritional support.
Right, when someone just needs a little boost.
Not the full meal deal like TPN.
Exactly. So for your exam listener, really make sure you understand those key differences.
Central versus peripheral complete versus less concentrated long-term versus short-term.
Those are the biggies.
Got it.
Now let's talk about what actually goes into these PN solutions.
Okay, let's get cooking.
Yeah.
What are the ingredients?
It's more than just sugar water.
Oh, it's a whole lot more than that.
So we've got the basic building blocks.
Like what?
Amino acids, which are the building blocks of protein.
Okay, gotta have those.
Dextrose, which is a type of glucose.
Our main energy source.
Electrolytes like sodium, potassium, chloride.
Keeping all those bodily functions running smoothly.
Vitamins.
Essential micronutrients.
Trace elements.
Those tiny but mighty minerals.
And of course, sterile water.
The base for it all.
To mix it all up.
So it's like a carefully balanced cocktail.
Exactly. And the dextrose concentration can vary a lot.
Oh, yeah. You mentioned that before. Why is that?
Well, it depends on the patient's needs.
Okay, makes sense.
For example, if a patient has fluid restrictions, we might use a higher dextrose concentration.
So they get enough calories without too much fluid.
Exactly.
Clever.
And if a patient's blood sugar is running high, we might lower the dextrose.
To keep things in check.
Right now, what about those other ingredients? The electrolytes, vitamins, trace elements.
Oh, yeah, those are important too.
They're all carefully adjusted based on the patient's blood tests and their overall condition.
So it's personalized nutrition.
Exactly. And I even saw in the materials that extra vitamin K can be added.
Oh, wow. Yeah, if the patient needs it.
Now let's talk about the lipids.
The lipids, the fats that give PN that milky look.
Exactly.
They come in different concentrations, 10%, 20%, and 30%.
And they're made from soybean and or safflower oil.
Okay.
and egg phospholipids.
What are those?
They basically help the oil and water mix together.
Oh, like an emulsifier?
Exactly, and this is a big one for your exam listener. There are certain cases when you absolutely should not give IV lipids.
Oh, that sounds serious.
It is. So if the patient has severe hyperlipidemia, meaning super high levels of fat in their blood,
Got it.
or if they have severe liver disease,
Okay.
or if they're allergic to soybean oil eggs or safflower oil.
No lipids for them.
Exactly.
So when would you use lipids?
Well, lipids are a great source of calories.
So they provide energy.
Right. And they're especially helpful when we need to limit dextrose.
Like if the patient has fluid restrictions or their blood sugar is too high.
Exactly. They also help prevent essential fatty acid deficiency.
Okay. Which can happen if someone's on PN for a long time without lipids.
Right. And here's another key point. Lipids provide a lot of energy without increasing the osmolality of the solution.
What's osmolality again?
Basically, it's a measure of how concentrated the solution is.
Ah, so lipids are like a sneaky source of energy. They don't add to the concentration.
Exactly. And that's really important when we're using PPN in those smaller peripheral veins.
Oh, because those veins are more sensitive.
Right.
So lipids are a win-win.
Now, the materials also talk about total nutrient admixtures, or 3-in-1 solutions.
What's that all about?
So this is when the lipids are mixed right into the same bag as the dextrose and amino acids.
Oh, interesting. So it's all one solution.
Exactly. It's not done everywhere, but it might have some benefits.
Like what?
Some research suggests it might reduce carbon dioxide production in the body
Interesting.
and maybe even reduce fat buildup in the liver.
Okay, so 3-in-1, potentially a good thing.
All right, now on to the protein component. The amino acids.
Amino acids, the building blocks.
Exactly. And those solutions come in different concentrations, too.
Oh, yeah. What's the range?
Anywhere from 3% to 20%.
And how do you decide how much someone needs?
It's based on their estimated protein needs and how well their liver and kidneys are functioning.
Right. Those organs are key for processing protein.
Exactly. And the pharmacy can add other things to the PN solutions, too.
Really? Like what?
Insulin's a common one to help manage blood sugar.
Makes sense.
Sometimes heparin to prevent blood clots.
Oh, in the catheter.
Right. And they can even add glutamine antioxidants, prebiotics, probiotics, all sorts of things.
Wow, it's like a custom-made solution.
It really is. And here's another really important point for your exam listener.
Okay, hit me with it.
Never, ever administer other IV medications through the PN line.
Okay, so that line is strictly for PN.
Exactly. It's super important to keep that line sterile and prevent any weird interactions.
Got it. Makes perfect sense.
Now let's talk about when a patient might actually need PN.
Okay, so what are the indications for this therapy?
Well, TPN is often used for patients who need a lot of nutritional support for a long time.
Like who?
People going through intensive cancer treatments.
Okay.
Patients with inflammatory bowel diseases that make it hard to absorb nutrients.
Makes sense.
People in the ICU who are critically ill.
Right. Their bodies are under a lot of stress.
And patients recovering from severe trauma or burns.
Those are all situations where you need a lot of calories and nutrients.
Exactly.
So TPN is there to step in and provide that support.
Right now, what about PPN? When would you use that?
PPN is typically for patients who can't eat enough, but their nutritional needs aren't as dire.
Right. So they might be able to eat a little, but they need some extra support.
Or maybe they only need PN for a short time.
Exactly. And the materials also mention home PN.
Home PN, that sounds intense.
It is, but it allows people with chronic conditions to get the nutrition they need at home.
Wow, that gives them so much more freedom.
Right. They often have a special catheter placed, and they can get the PN overnight while they sleep.
So they can live a more normal life during the day.
Exactly. Now, how do we know if the PN is actually working?
Ah, good question. We want to see results.
Exactly. So what are we aiming for?
The main goals are to improve the patient's overall nutritional status,
Okay.
to help them maintain or even gain weight if needed, and to achieve something called a positive nitrogen balance.
What's that?
It basically means that the body is building more protein than it's breaking down.
So it's a sign that the body is using the nutrients effectively.
Exactly.
Oh.
And we can track all of this with some objective measures.
Like what?
We monitor their weight daily,
Okay.
and we look for a gradual weight gain up to about 1 kilogram per day.
Anything more than that could be a sign of fluid overload.
Right. We also check certain lab values like prealbumin.
Prealbumin, what does that tell us?
It's a good indicator of short-term nutritional status.
And what's the normal range?
Around 15 to 36 milligrams per deciliter.
Got it. And what about BUN?
BUN stands for blood urea nitrogen. It reflects kidney function and protein metabolism.
And the normal range for that?
Is 10 to 20 milligrams per deciliter.
Okay, so for our listener who's studying for their LPN exam.
Yes, for our future nurse.
It's really important to understand these goals and these lab values.
Absolutely. It's all about evaluating whether the PN is doing its job.
Now let's shift gears and talk about the role of the nurse in all of this.
The nurses are the frontline heroes.
They really are, and they have a ton of responsibilities when it comes to PN.
What kinds of things?
Well, it starts with careful preparation before the PN even begins.
Okay, so what goes into that?
You need to review the patient's entire medical history.
Like their weight, their BMI, their nutritional status, their diagnosis.
And a whole bunch of lab results.
Wow, like what kind of labs?
Complete blood count, a full chemistry panel coagulation, studies iron levels, lipid profile liver function tests, electrolytes, BUN, and creatinine prealbumin, and albumin blood glucose and platelet count.
That's a lot of labs.
It is, but it gives you a really complete picture of the patient's health.
Makes sense. Got to have all the information.
You also need to assess the patient's and their family's understanding of PN.
So education is key.
Absolutely. You want to make sure they know what to expect.
Of course.
You'll also be using an electronic infusion device to deliver the PN.
To make sure it goes in at the right rate?
Exactly. And you'll need a micron filter on the IV tubing.
What's that for?
It filters out any particles that could be in the solution.
Oh, to keep things clean.
Exactly. The only exception is when you're infusing lipids.
Okay, so no filter for lipids.
Right. And of course, you always want to check for allergies.
Especially to soybeans, safflower, and eggs if they're getting lipids.
Right. So that's a lot to do before you even start the PN.
Wow. Yeah, nurses are busy.
But the care doesn't stop there.
Oh, no. What else is there?
There's ongoing monitoring and care once the PN is running.
Like what kind of monitoring?
One important thing is to watch for something called cracking of the TPN solution.
Cracking, what's that?
It can happen if the calcium and phosphorus levels are off or if the wrong type of albumin is added.
And what does it look like?
The solution will look oily or have a layer of fat on top.
Yuck. So what do you do if you see that?
You never, ever give that solution to the patient.
Okay. That's a big no-no.
You have to send it back to the pharmacy. What else? You always have to verify the PN prescription with another nurse.
Double-checking safety first.
Exactly. And if the PN solution has been in the fridge, you have to let it warm up to room temperature before giving it.
That makes sense. Cold IV fluids can't be comfortable.
Right. And sterile technique is absolutely crucial throughout the entire process.
Why is it so important?
Because that high dextrose content in PN is like a bacteria buffet.
Oh, so it can get contaminated easily.
Exactly. So you have to be super careful with everything you do.
Sterile gloves, sterile dressings, the whole 9 yards.
Exactly. And you have to change the dextrose solution bag and tubing every 24 hours.
Okay, so fresh tubing every day.
Right, unless your hospital has a different policy.
Makes sense.
And if you're giving lipids intermittently, those bags can only hang for 12 hours max.
Got it.
And if you need to check the patient's triglyceride levels, you have to stop the lipid infusion 12 hours beforehand.
Okay, so no lipids skewing those results.
Exactly. So that's a lot to keep track of.
It really is. Nurses have amazing memories.
Now let's focus on the specific nursing actions that are essential for patients on PN.
Okay, so what are the must-dos?
The main focus is preventing complications.
By staying vigilant.
Exactly. So you're constantly monitoring the patient.
What do you monitor?
Their intake and output, their daily weight, their vital signs, and all those lab values we talked about.
Especially electrolytes and blood glucose.
You're also constantly assessing their overall condition and how they're tolerating the PN.
So it's a lot of observation and assessment.
It is. And blood glucose monitoring is especially important because of all that dextrose.
Right. We don't want those blood sugars going haywire.
Exactly. So you'll be checking their blood and urine glucose regularly.
As ordered by the doctor.
And if they develop hyperglycemia, you might need to give them insulin.
Okay, to bring those blood sugars down.
Sometimes the insulin is even added right into the PN bag.
Oh, wow. Right in the mix.
You also have to monitor the PN infusion rate really carefully.
Why is that so important?
Because if it goes in too slowly, they won't get enough nutrition. And if it goes in too fast, it can cause problems like hyperosmolar diuresis.
What's that?
Basically, it means that the high glucose levels pull extra water into the urine, which can lead to dehydration.
Oh, that doesn't sound good.
It's not. And here's another important point. If the next bag of PN isn't ready when it's supposed to be,
oh, that's a problem.
you can't just speed up the next bag to catch up.
Why not?
Because it could cause all sorts of problems.
Oh, like hyperglycemia and fluid overload.
Exactly. So what do you do instead?
I'm all ears.
You give them an IV of 10% or 20% dextrose in water.
Okay, so they still get some glucose, but not too much too fast.
Exactly. And this is a really important point for your exam listener.
Write that down.
Never, ever speed up the PN infusion to catch up.
Got it.
Now, for patients on long-term PN, the doctor might actually order some enteral nutrition too.
Enteral meaning through the gut.
Right, even though they're getting most of their nutrition intravenously.
Why would you do that?
It's basically to keep their gut working.
Oh, to prevent it from getting lazy.
Exactly. Even a little bit of food or formula going through the gut can help prevent it from atrophying.
Atrophying meaning?
Wasting away, basically.
Okay, so it's like use it or lose it for the gut.
Exactly. Now, when it's time to stop PN, it's not something you do suddenly.
You have to wean them off slowly.
Right. You gradually decrease the PN as they start eating more.
Okay.
And you start them on clear liquids first.
Easy on the tummy.
Exactly. It might take a while for their appetite to come back fully.
And for patients going home on PN education is super important.
Absolutely. You want to make sure they know how to handle the PN safely at home.
Like how to keep everything sterile.
How to check their blood sugar.
And what to do if they have problems.
Exactly. So for our listener who's prepping for their LPN exam, preventing infection and managing blood glucose are huge.
Those are high-yield topics for sure.
Okay, now let's talk about the scary stuff.
Complications.
Yep, because things can go wrong with PN.
Of course, it's a complex therapy.
So one of the biggest risks is infection and sepsis.
Sepsis, that's a serious bloodstream infection.
Right, and it can happen in a few ways.
Like how the
Catheter could get contaminated during insertion.
Okay.
The PN solution itself could be contaminated.
Oh.
Or even just having a catheter in for a long time can increase the risk of infection.
So lots of potential sources.
And what are the signs of infection?
Fever, elevated white blood cell count.
And then there are the metabolic complications.
What kind of metabolic problems?
Well, we already talked about hyperglycemia.
From all that dextrose.
Right, but you can also get hypoglycemia if the PN is stopped too abruptly.
Oh, that makes sense.
You can also get electrolyte imbalances.
Like too much potassium, too little phosphate, too little calcium.
Exactly.
That's a lot to keep track of.
It is. You can also get dehydration from hyperosmolar diuresis.
We talked about that earlier.
Right. And on the flip side, you can also get fluid overload.
If the patient gets too much fluid.
Exactly. And then the mechanical complications.
Problems with the catheter itself.
Right. So the catheter could get misplaced during insertion.
Oh, that's not good.
It could cause a pneumothorax or a hemothorax.
Which means?
Air or blood in the space around the lungs.
That's serious.
It is. And the patient might have trouble breathing or have no breath sounds on that side.
Scary.
Other mechanical complications include arterial puncture,
Ouch.
catheter embolus air, embolus thrombosis obstruction, and even a bolus infusion if the pump malfunctions.
So lots of potential problems with that catheter.
And then there's something called refeeding syndrome.
Refeeding syndrome, what's that?
It's a really serious complication that can happen when a severely malnourished person starts getting nutrition again too quickly.
Or their body freaks out.
Kind of. It's like their metabolism goes from a starvation mode to an overdrive mode.
And that causes problems.
Big problems. It can cause fluid and electrolyte shifts, heart problems, breathing problems, even seizures.
Wow, that sounds really dangerous.
It is. So it's really important to monitor patients closely for any signs of refeeding syndrome.
Especially those who haven't been eating well?
Exactly. So for each of these complications, there are specific nursing actions you need to take.
Okay, so what can nurses do to prevent and manage these problems?
Well, for infection, it's all about meticulous sterile technique.
Makes sense.
And watching for any signs of infection like fever.
And checking those white blood cell counts.
Right. For glucose imbalances, you're constantly monitoring blood glucose and giving insulin or dextrose as needed.
To keep those levels stable.
And for fluid overload, you're watching their weight and looking for signs of edema.
So basically, it's all about staying vigilant and catching problems early.
Exactly. And your study materials have a really handy section called the Active Learning Scenario Key.
What's that?
It summarizes the key nursing actions for things like infection, hyperglycemia, hypoglycemia, and weight gain.
Oh, that's a great resource to review.
Now, for our listener who's getting ready for their LPN exam.
Yes, our future nurse.
It's important to understand how all of this PN stuff relates to the NCLEX.
Right, because the NCLEX loves to test on this stuff.
So PN is relevant to several key categories on the NCLEX.
Like what?
Health promotion and maintenance.
Okay.
Basic care and comfort. physiological adaptation,
Got it.
and reduction of risk potential.
Those are all big categories.
They are. And within those categories, you might see questions about things like identifying risk factors for malnutrition,
Makes sense.
educating patients about PN,
Important.
providing nutritional support,
Essential.
managing fluid and electrolyte imbalances,
Essential.
and assessing for complications like aspiration or hypoglycemia.
So basically everything we've talked about.
Exactly. And your materials specifically highlight the pharmacological and parenteral therapies category
Okay.
and the nutrition and oral hydration topics.
Those are definitely PN heavy.
Now, your study materials also have some practice questions.
Oh, let's go through those.
The first one is all about lipid emulsions.
Okay. What do we need to know about lipids?
The correct answers highlight that lipid concentrations go up to 30%,
Okay.
that they give the solution a milky appearance.
You have to check for allergies before giving them,
Important.
and that their main purpose is to provide fatty acids and calories.
Got it.
The incorrect statement, and the one to watch out for on your exam, is that lipids increase the osmolality of the solution.
Ah, so they don't make the solution more concentrated.
Exactly. Question 2 is about medication compatibility.
What can and can't you give with PN?
The key point is that regular insulin can be added to TPN,
Okay.
but you should never give any other IV meds through the PN line.
That line is sacred.
Exactly. Question 3 talks about what to do if you see fat globules in a bag of lipids.
What's the verdict?
You send that bag back to the pharmacy.
Don't use it.
Nope, it's not safe.
Got it.
Question 4 asks what to do if the next TPN bag isn't ready on time.
That's a tricky situation.
The right answer is to give the patient 10% or 20% dextrose in water.
To prevent hypoglycemia.
Exactly. And the last question is about PPN.
What do we need to know about PPN?
The correct answers emphasize that you need to monitor the patient's weight.
Check their prealbumin levels.
Right.
Use a micron filter. And use an infusion pump.
So all the basic nursing care stuff.
Exactly.
Yeah.
So there you have it, listener.
You're ready for that LPN exam?
We've covered all the essentials of parenteral nutrition from your study materials.
We hit all the high points.
We talked about TPN and PPN, the ingredients,
Yep.
the indications, the nursing care, and the complications.
It was a whirlwind tour.
It was, but hopefully it was helpful.
I hope so too.
So as you study for your exam, really think about how different patient situations would call for either TPN or PPN,
Makes sense.
and how important it is to monitor patients closely.
To prevent those complications,
Kind of how vital your role as an LPN will be in managing this therapy.
you'll be a PM pro.
And remember, understanding the why behind all of these practices will not only help you on your exam, but it will also make you a better nurse.
Absolutely, knowledge is power.
Good luck on your exam, listener.
You got this.
And we'll see you back here for another deep dive soon.
Until next time.
Bye.